All levels.
All levels.
All levels. Okay. Maybe this is one thing, as a policy issue, as a request to the government that, this. See, for example, I just want to look at the Malayalam-speaking people, their profile of diabetics, non-communicable disease profile, or age-wise, gender-wise, certain disease profile. That data is not in the full system.
Okay.
See, unless we look at this, for example, our community, how better they are doing with non-communicable diseases, because that's the challenge coming up. Non-communicable disease profile is coming up. But when you look at empirically with evidence and data, that data systems are not collected on this extensively.
Okay.
So maybe it's a policy issue, it's a government policy issue.
So that data is not collected in terms of the profile, the cohort profile of this of the workforce.
Not only workforce, no. all across.
All
this
across.
Is a vertical issue. It's not only one issue. It's broadly one issue. Because see, one of the exercise we did is that we looked at the socio-economic and health profile of our community. Then both of our researchers, she's just finishing her PhD, and my PhD is in public health. So we looked into that, and we looked at to get the data, because the federal government is collecting that data, but then state government is also supposed to support and contribute towards that. But this issue, unless you have a longitudinal data, you may not be able to predict what are the healthcare needs. For example, demographic need. We know that there is a gender difference in dementia, gender difference in aging requirement. But we need very specific data. Are they going to face with dementia or maybe dementia with diabetes, dementia with heart disease? For decision making for the community leaders also we require that level of precise data.
It's quite detailed,
right,
and cross. Okay.
Can I ask, is there that kind of data with general population?
General population
there is.
Okay. It is for general population.
Yeah, and also there are general data for each community. But we looked at, because the Malayalam, there is a code for the ABS and Australian Statistical Bureau data collection. Each language is codified and defined in five variables. But that data collection is not getting into our, for example, our bulk billing. That level is not enforced that way.
And so in the health setting that you are in, can I ask where you work? Where are you?
I work with with a registered training organization. I'm a public health, and I'm creating a syllabus for masters in public health. We just submitted it to TEXA, waiting for the approval.
To who?
TEXA is the regulatory authority for the higher education.
Yeah.
So, and we're back and forth, we're negotiating for that approval. Hopefully by November we get the approval for a new masters in public health.
Okay. And has the organisation you work for, have they made representations to government about the need to?
Not yet. No. Because this is when there are many issues. One is this, we try to look at it. Then I'm trying to submit a research proposal to NHMRC, National Health Research Foundation, looking at the longitudinal monitoring of health needs of the culturally and linguistically diverse population, and particularly on Malayalam speaking community as a research proposal. Then I did my background looking at the data. Then I realized that this data doesn't exist. And I wrote to them at National Family Health Institute. They said they don't have that data. Then I realized that maybe when I get a chance, this is the one thing we will put it forward on that.
Yeah.
Because in the modern world, if no data means you don't exist.
Which organisation should be collecting that data?
It should be a policy from the federal government and state government that in all aspects of data collection, there should be a mandatory element on culturally and linguistically diverse populations, all other variables which we collect for any information.
Yeah.
See, for example, let me give a specific example about bulk billing. Bulk billing, do we have data on which language group, and what disease profile, and how many of them are using bulk billing, how many are using? That data is important to see the emerging healthcare needs of any community. I'm not talking about only Malayalam speaking, but we notice this when we start looking at it. This need very specific, because we are talking about more than 300 language groups here. So that also should be an additional element of our, but I know it's a very tedious process because we're collecting data from 300 community groups, but that's a matter of creating a system to collect that.
Well, that's it. And at the end of the day, it's probably an additional 1 or 2 questions that get
That's
asked.
it, yeah. And the coding issue. It's just a matter of coding that. When you, anywhere the data is coming up, recoding it that way.
I mean, the community health benefits of that information are very can be very real. So I know anecdotally, for example, a good friend of mine, he's passed away sadly a few years ago, Sri Lankan, Tamil, Catholic anyway. He had a heart attack a few years ago in hospital, and the hospital staff told him, it's anecdotal, that the ones who seem to have the worst in terms of heart disease is the Indian subcontinent and Italians, because of the type of food they eat. But that's anecdotal. But that's not good enough, is it? I mean, and that's one thing. But the thing is, if you actually had the data, you could then much better tailor the preventative strategies, education, all of those things to particular communities in a way that understands, well, they are more likely to develop diabetes, or they're more likely to develop blocked arteries, whatever it might be.
Because again, it's a common research that people from Asian continent who had gestational diabetic, whose tummy circumference is bigger than the chest, will develop diabetes. So that's a research, and all the doctors go by it.
Gestational diabetes in our South Asian population is 24%,
Right.
whereas other general population is 4%. There is a clinical implication for that. Many of the general physicians may not pick up the gestational diabetic symptoms because it happens at the last trimester, the last 10 days before that.
Oh, I see.
And that screening may not, that precise screening should come only if you are aware of this person belongs to this particular community.
Yes, and
their health profile is come out.
and they're more likely. So like with age, we know that you know, if women become pregnant after a certain age, you may, you know, it's probably best to test I don't know what the new techniques are, but amniocentesis for Down syndrome testing, those types of things. So, but we only but we're limited in terms of the health intervention on the data that we collect.
Because this is a very specific requirement of certain very microscopic communities, because health profile varies. Same about cardiovascular diseases. And migrant population, in principle, they are the healthiest population because they go through all the checking before you come to Australia. But then that advantage they lose rapidly. One reason that what we call it as, we call acculturative stress. The adaptation creates extreme level of stress among them. Okay. That stress contributes towards heart disease and diabetes, I feel. And that level of data we don't know. No. See, we don't even know where the prevalence of diabetes among each community and the prevalence of heart disease in specific community groups. And that's what I mentioned, the data collection important even in all aspects.
Is there any country that does it? Is there any system that does it well, that does it like that? No.
Because Australia is the best in the world.
Yeah.
And the best in the world, if you can see this, UK they have some, but then UK also they do generally, broadly South Asia, India, Bangladesh, that's a broader classification. Within that subgroup they're under classification. But here you have a linguistic classification, all these 300 language groups are classified and numbered. So it's just a matter of coding that way. So for example, Malayalam is 4,200 or something the number. That, if you can come out with all the data just by this one variable, I mean, these are the policy making is
it needs the policy decision. Yeah, it seems like that it's something that probably would be best managed at a federal level.
Yeah, right, of course.
Especially if you're linking it to Medicare.
No, it should come both. I mean, there are various ways that way. But this is a national policy issue. Data collection on culturally linguistically diverse population and their subgroups should be a government policy, federal level and state level as a mandatory policy.
Should be a government policy.
Government policy.
Alrighty. So look, I'll mention it to the Health Minister in Victoria when I see her
Right,
next week.
yeah.
I'll probably see her,
Mm-hmm.
see what her thoughts are about
Yeah,
it,
sure,
whether
right,
it's
right,
on
right.
the agenda, because you know the health ministers get together across.
Sure, right.
See what she says about it.
Yeah,
yeah.
yeah. And I could give you a briefing paper on what is the issues behind it, because we've done our homework to
Yeah,
see that.
yeah.
You can send a note on what's happening that way.
Well, you know, if you'd
Mm.
like to share something with me, because
Mm.
maybe I might write to her.
Please.
Yeah, that's probably the best thing to do. That way I'll get a more
Mm.
formal consideration of it from
Right,
the
right,
department,
right.
the health department in Victoria. How about we do that? Is
Yeah,
that you want to
No,
share that with me?
maybe what I would suggest is that asking for the details for the data collection on culturally, linguistically minority, diverse population and the subgroups.
Mm.
What effort can be taken to an extensive data collection? All the maybe I can send my request as one of the constituents that asking you to look into this, so you have something to specifically
Yeah.
work on.
No, I will say that that this has been raised by yourself with me, and and that I'm seeking the information and the consideration of the a policy change.
Yeah,
Okay, we'll do it that way?
Sure.
Excellent, that's great. So whatever you send me, if you can please just put what the problem is that you identify,
Definitely, yeah.
and then what you think the solutions are, and that
Sure,
way
yeah.
I can...
No, I'll send you a ministerial briefing on that.
You don't have to send a full ministerial briefing.
No, I've done it in my life, previous life, that's why.
Okay. That would be good, let's do that.
Sure,
Yeah,
right.
yeah.
So thank you,
Yeah.
Lily, for
No,
your
not at all.
time. It's been really appreciative of your time for us.
Not at all.
We haven't taken too much of your
No, I'm very happy. So just one thing before I forget, I think it would also be a good conversation to have with Andrew Giles,
Okay.
who's the federal member, because he may also, you may also wish to ask him to make representations to the federal Minister for Health. And we look, I'm sure that and our two officers can work together. Like he can, he'd send a letter, I'll send a letter, and that way we see what we
most.
Yeah,
Okay.
we can do that.
My profuse apology for getting delayed.
No.
I coming from South Area, so it took.
No, no need to apologise at all. Do you live around here locally?
My sister is living here,
Mhm.
but I live between South Area and here.
Yeah, okay.
We had an interview this morning with the Consular General of India.
Oh, how did that go?
It went pretty well.
Yeah.
He sort of wanted some questions to be sent to him, which we are going to do.
Mr. Kumar, is it?
Social
Mr.
Kumar.
Kumar,
Yeah, that's it.
Yeah.
Yeah.
And tonight we were planning to, but it got cancelled. We had one of our oldest, the first migrant to Victoria from Kerala. So she lives in Bandura. So she had to cancel it. So we were going to talk to her to see what was it like when she migrated 30 years ago. So she's one of the first migrants. Her husband has got dementia now, is in a nursing home. So she's gone through quite a tough period, and she's in that stage where there's limited support. Husband is in a nursing home.
Okay.
So we're just getting perspective from everyone to put it in our civil area.
That's very good. That's very good. That's a few years ago, and I'm making this longer now, sorry.
No, that's okay.
It just reminds me about 15 years ago, I helped, there was someone in the Italian community that wanted to do some storytelling. Is there a grant available? Anyway, so what we decided was that we went to the Australian Centre for the Moving Image. Do you know ACME?
Actually,
And we got a grant from the Multicultural Commission, and ACME obviously provided some support, not some in-kind support, because they're the experts. And we did a series of digital stories, and just to take we'll take a collection of storage and images from about 10 individuals about their journey. It's a lovely way to capture the stories.
So this
days
will be like similar like this.
And you've got better means to do that now, the technology than was 15 years ago.
So these
It's a
videos
lovely
will all
thing
be
to do.
compiled. It will be a storytelling,
Yeah.
but it will be a storytelling about the current scenario and the future of the migrant community.
Yeah,
And we
good.
may create a kind of a digital collage, maybe, a few seconds from everybody.
Yeah, that's it. That's
Yeah.
exactly right.
Yeah.
Yeah. I didn't realise we were doing a video today because I didn't put my makeup on. I hope it's all right. I apologise.
As I said, you look beautiful. You're always present to
Oh, I
me.
don't know.